Hello, future PTAs. I hope you guys are doing well. Today we're going to talk about neuroplasticity. So we'll cover brain injury, the mechanics of mechanisms of recovery, and the effects of exercise and therapy on functional recovery. With traumatic brain injury, this is when there's mechanical trauma to the brain. It occurs when the head strongly impacts an object. The coop injury is the injury at the site of impact. So in the picture at that front there would be the coop injury. And the countercoop injury is the injury on the opposite side of the brain where the brain hits the skull. And so there's often two areas of injury. And the countercoup is the most severe injury, oftentimes, where it has hit the inside of the skull. But both are considered to be focal lesions, where a specific region of the brain is injured. So these could happen when the head actually hits an object or when an object, like a baseball or something, hits the head. It can also happen when the brain is shaken forcefully, even if something doesn't directly hit the head. Focal lesion, this is the localized specific area of the brain that's damaged and has very predictable symptoms. As swelling and things occur, it actually spreads, and then there's more generalized damage to the brain. So that would be diffuse axon injury. So this is a widespread shearing of the central nervous system axons. Often it's related to rotational forces where the brain actually drags against the inside of the skull. It can be devastating to brain tissue. One example of both a focal lesion and diffuse axon injury is shaken baby syndrome. So when the baby's brain is shaken and it has a lot of room to kind of move around in the skull, it creates coop and countercoop injuries as well as these diffuse axon injuries. So it can be devastating. Hypoxia and anoxia. So hypoxia is just decreased oxygen, whereas anoxia is a lack of oxygen, very similar. Both are causing a lack of oxygen to the brain, and that will cause damage. Anytime an area is not getting the oxygen it needs, damage will occur. So neurons in the brain can typically only survive about 3 minutes without oxygen before they begin to die. And if you are without oxygen for an extended amount of time, then typically there is widespread neuron death and a brain injury. Some of the examples of things that could cause a hypoxia or anoxia brain injury would be near drowning, heart attacks, or anything that compromises the blood flow to the brain, like decreased intracranial pressure, or if the carotid artery becomes occluded and the blood isn't being pushed up to the brain. Neuron response to injury. So the area after it's injured, the neuron itself causes some swelling in the area. The cell body is ruptured and it leaks the cell contents. So different things like enzymes, calcium neurotransmitters leak in the area, and they're all neurotoxic. So they kill surrounding cells and the damage spreads. And then the more swelling that occurs, the more damage that continues to occur. With blood flow damage, if there's an injury to a small blood vessel, then it could cause blood to pool, places pressure on the surrounding tissues, and then the blood loss and the compression from the pressure of the blood gathering in that area both cause widespread damage. Swelling response also compresses the brain and spreads the damage more. So some of the small blood vessels we're talking about are the capillaries, the arterioles, the venules. Other things like infection could also cause brain swelling, like a bacterial meningitis. And when the brain is swollen, of course, we call that encephalopathy. And this can also damage the neurons. Axon damage in the central nervous system causes the axons to die. So remember, when the axons in the central nervous system die, although they're able to form a growth cone, the cell body can form a growth cone. That growth cone cannot elongate throughout the brain or spinal cord. And so it just basically starts to repair itself and then dies because it cannot regenerate in the brain or spinal cord. But in the peripheral nervous system, after that growth cone forms, it elongates and can form a new axon. Now, as long as that axon reaches another neuron or reaches the end point, then it can, regenerate. It can thrive. But if it does not reach it fully, it still dies. Microglial cells are the cells that remove the dead axons. And they think that one of the reasons that the peripheral nervous system has the ability to regenerate is that there's specific growth factors in the peripheral nervous system that help with that regeneration that aren't present in the central nervous system. Levels of consciousness. So the old terminology, there were just kind of 3 levels of consciousness. There was a coma where the eyes are closed and the patient is unaware, which typically lasts up to 4 weeks. And then a vegetative state where the eyes are open, the patient has a sleep and wake cycle, but they're unaware of their environment. And then there's the minimally conscious state where a patient has some awareness of the environment, like maybe they can do a squeeze my hand, if you can hear me or something like that, but may respond, to simple questions, but not a lot of interaction with their environment. When somebody is in a coma or a minimally vegetative state, the longer that they are in that, the worse the prognosis is. With the new terminology, with the Glasgow, new terminology, I skipped a slide. New terminology, the levels of consciousness include more descriptive terms. So coma is still unconscious, unresponsive to all stimuli. A stupor, they're still generally unresponsive, but they are able to arouse a little bit to repetitive stimuli. So sometimes like a sternal rub, like it's uncomfortable, or, tapping or shaking a little bit, or somebody saying their name over and over, or maybe tickling their feet or doing something that's like a little bit aggravating, typically will maybe cause them to open their eyes, maybe even look towards the stimuli, but not a lot of activity going on. With obtundity, they're primarily asleep. There's a low level of alertness at times and a very delayed response to stimuli, but sometimes they are able to respond to stimuli. With delirium, there's a disorientation, some confusion. They may be agitated. They may get loud when they are awake. So there's more awake time during this, but it's very disoriented. With a clouding of consciousness, this is kind of a really widespread prognosis, as far as like you could have a clouding of consciousness and be on one end and it be very severe, or on another end where it's not as severe as you heal. So quiet behavior, still some confusion there. There's poor attention. There's delayed response. They may make sense for a minute and then speak in things that don't make any sense. So there's a lot of I can't think of the word for it. Don't be surprised because I always forget words. But it's a spectrum in the clouding of consciousness, a lot of variations in that level. And then consciousness, they're alert, they're oriented, they're aware, and they're able to remember. The Glasgow Coma Scale is a scale that we use to assess the patient's coma and track their progress. So there are 3 responses that we look at: their eye-opening, their best verbal response, and their best motor response. So this is not like they're talking all the time, but when they do talk, the best response I'm getting from them. So each of the categories are graded. So with eye-opening, it goes 1 to 4, with 1 being the eyes are remaining closed all the time, and 4 being that they open spontaneously to interact with the environment. With the verbal response, 1 is there's no verbal response whatsoever, versus 5, the best verbal response, which is they're fully oriented. With the best motor response, 1 would be no speaking whatsoever, and 5 would no movement whatsoever. I'm sorry, we're talking about motor response. And 5 being obeying your commands and following your instructions. The lower the score is, the more serious the brain damage is. So here's some of the things that happen after brain damage. Oftentimes the patient will have seizures, they'll have language problems, maybe understanding the language or speaking the language, paralysis and loss of sensation in areas, ataxia, so that's that lack of coordination, long-term cognitive problems, memory problems, difficulty learning new tasks, difficulty even performing routine tasks that they've done. The deficits all depend on the area of the brain that's affected, and deficits may arise with time as secondary complications. Like if they're immobile, then it may eventually lead to pressure sores or heterotropic ossifications, which is where bone develops in tissue that's not being used. So bone developing in the muscle. Contractures are common when people aren't moving. So some of the problems are directly related, and some of them over time develop because of those primary issues. Brain recovery. So although the central nervous system, those neurons do not regenerate, there is a possibility of functional recovery after brain injury. So what happens is the surviving neurons actually just take on new tasks. They rewire to work on areas of the brain or spinal cord that they typically would not control. So they kind of sprout out and start affecting or controlling or getting sensation from more areas than they previously did. Even after serious brain injuries, it is possible for a functional recovery. What level of function? It depends. So several ways that the brain recovers. There are 3 ways in general: axon sprouting, activation of parallel pathways, and neurogenesis. And so with the axon sprouting, what happens there is this is primarily in the spinal cord, and the healthy axons produce new branches to travel through the damaged areas and form new synapses. So as you see in that first picture, it's, one cell body to just a few skeletal muscles or motor nerves. And then with the next one, it sprouts more and more branches so that it's able to control and create impulses that go to more and more motor neurons. They may not be able to grade their muscle contraction as well, or to have as much control initially, because one neuron is kind of activating so many, but that can increase function. And that the same thing can happen with sensory neurons and with motor neurons. Activation of parallel pathways. So this is when healthy neurons take on new functions. With more time, with more practice, more synaptic connections are formed along the new pathways to improve your function. And physical therapy is key in this activating parallel pathways. So the more movement, the more functional things that they do, the more pathways that begin to activate. With neurogenesis, this is growth of new neurons. It occurs in the hippocampus and olfactory epithelium. But the neurons must establish a connection with other neurons, or they will be pruned and eventually die. So some of the things that stimulate neurogenesis, that stimulate that healing and that recovery. So neurons in the hippocampus form more connections in people who are physically active and mentally stimulated. So we want to get people moving and thinking. So exposure to a mentally and socially enriched environment helps with learning, with memory, with function. This stimulation appears to release neurotrophic factors that help activate genes to form new synapses. So the more you move, the more you challenge yourself, the more growth and recovery that is possible. Studies have shown that people who walk daily demonstrate improved performance on cognitive function tests, including improved ability to concentrate, to handle multiple complex tasks, And on the flip side, people who are stressed or who have taken certain medication or certain drugs have fewer neurons. And we've talked about in previous lectures, but if they have those conditions, chronic stress, drug use, or even prescription drugs sometimes, or depression, the hippocampus in that person's brain actually shrinks. And chemotherapy could do the same thing, drugs that prevent cell division. But if they are able to get off of those medications or to start moving again or to get help with the depression, then the hippocampus is able to grow and increase in size. So effects of exercise on functional recovery. Exercise, of course, increases the blood flow to the brain, and it increases the number of cells involved in memory and in concentration. More synapses among neurons, improve functional return after damage. So a lot of things are going on in the brain when we move that are helpful for functional recovery. Cells that increase are typically located in the hippocampus, as we talked about, and parts of the frontal and temporal lobes, which is where a lot of our movement and our processing occurs. Neuroplasticity. So this is the brain's ability to reorganize itself based on experience. This is how we learn and how recovery takes place. And it includes synaptogenesis, which is the formation of new synapses, and neurogenesis, the formation of new neurons. Neurons that are frequently activated form more synapses. So the more you practice something, the more that recovery happens. Okay, you form new connections in the brain. CIMT is constraint-induced movement therapy. Your book actually refers to this in some areas as forced use, but you basically constrain the affected side by either a brace or an oven mitt or something that keeps you from using that side, and it actually forces you to use the affected side more, and they go through a very specific routine of physical therapy. Ideally, it's for like 6 hours a day, 5 to 7 days a week, where they are doing a lot of fine motor and functional tasks in order to rewire the brain to increase the pathways and the use of that affected arm. Typically, this is done with the arm, not the leg, and it's to help with that neuroplasticity. Neuroplasticity is also called adaptability or flexibility. Neglect in neuroplasticity. So neglect is where you ignore one side of the body because of brain damage. Most of the time, it is the left side of the body that gets ignored because of brain damage on the right side of the brain. And it can cause people to run into things on that side, to fall over towards the affected side, or to try and push towards the affected side with the strong side. Some of the techniques that we use in physical therapy that really can help increase somebody's awareness and help some of those pathways rewire and those neurons to really sprout out and control more areas. Include weight bearing through the affected side, reaching towards the neglected side, active and passive range of motion, especially if they're looking at that, and then mirror therapy or looking towards the affected side. So almost always when somebody has neglect on one side, I try to put a mirror in front of them while we're doing balance training or while we're doing specific tasks to try to increase their awareness of that side. And the more they are aware of it and see it and feel it, they may even rub on that side with the unaffected while they're looking at it, the more their brain actually acknowledges that side and begins to repair and regenerate so that they can increase the use of that side. So physical therapy can increase your neuroplasticity and decrease the effects of that neglect. All right, enjoy life, get some exercise, laugh a little. All these things are great for the brain. I will see you in the next lecture, and have a good one. It won't let me stop recording.